Okay. Well, hello everybody. Thank you for spending your lunchtime with us. I'm Stephanie Duggan. I'm the Chief Clinical Officer, and I'm also an emergency room physician. And I still practice clinical shifts, and high reliability is something that I have a lot of passion around. And we as an institution very much believe in highly reliable healthcare, because what we're trying to do is decrease variability and increase the consistency that we deliver the same kind of care with truly behaviors that will represent safety for our patients. So this is designed to be interactive. Feel free to ask questions, raise your hand, let me know if there's anything I can clarify. And I've been told that I really need to stay behind the podium, so if you see me starting to wander, I'll get flagged back over. So I'm working hard to actually stay still. So how many of you have heard of highly reliable healthcare? Excellent. What are some of the principles of high reliability? Sorry, yell at me, I'm having a hard time hearing up here. Deference to expertise. Yes, and the expertise does not mean a title. The expertise means the person closest to the actual problem or item that you're actually working out. What else? How about a preoccupation with failure? If we're not preoccupied with what could go wrong, then we'll actually miss it. So keep those two in your mind as we go forward with this. So what is our goal? Our goal is to eliminate preventable patient, visitor, and associate harm and serious safety events by using highly reliable behaviors, and also to provide a safe environment for all people. So as we go through over the next hour, we're going to talk about how errors and events happen, understand how to prevent errors, and also utilizing safety behavior and error prevention tools. How many of you are actually caregivers at the bedside? Raise your hand. Okay, and how many of you are caregivers? Everybody raise your hand, okay? Because it doesn't matter what your role is. When you work within the hospital system, you are a caregiver. And I teach a lot by using stories. And so I'm going to share a story about my mom. And my mom, unfortunately, has had 2 major strokes over the last 4 years. She was a speech therapist by background and did not show up for work. She was 72 years old, and they found her on the floor of her kitchen, and she had had a hemorrhagic stroke. And so when I called the hospital to find out how she was doing, because I was currently in Florida and my mom was actually still living in Michigan, and I called the emergency department and I said, hey, this is Stephanie Duggan. My mom, Annie Juster, has just been transferred into your hospital, and I'm just trying to find out what has happened to her. And you know what happened when I said that? What's that? Well, I was told that I was calling from an out-of-state number and they couldn't verify that I was who I said I was, which was all very part and proper of the highly reliable approach. But you know what we do in healthcare, right? We figure out a way to have things happen. So I hung up the phone, I called back on my cell phone, which is a Michigan area code still because I hadn't changed it, and I said, hi, this is Dr. Duggan. Can I speak with the attending who's caring for Annie Juster? And so we solve things and we get around things. I'm not proud of the fact that I did that, but we need to find systems that are reliable and work together. And my point in that is everybody is a caregiver, whether you are caring for that patient directly, whether you're answering phones, whether you're helping clean the area, whether you're delivering food to the patient, we are all caregivers. And so just keep that in mind, and please encourage everyone that is not a traditional caregiver that their attitude and their approach to the patients matters, because many of those folks actually spend more time interacting with the patients than we do due to all of the charting and things that are required of us. So just keep that in mind. Safety. And safety is the cornerstone to everything that we're talking about today. And you can see associate satisfaction, time, quality, patient satisfaction, finance, and physician satisfaction are all important. But if you don't have safety at the top, it doesn't matter. Now, this is one of my all-time favorite slides because it talks about culture. And we all know that culture eats strategy for lunch, right? And what is culture? It's the shared values and beliefs of the individuals in the organization, or really the way we act when no one is looking. And it's these behaviors and the way that we act when no one is looking that really determine our outcomes. I'm going to give you an example. When someone sees your name on the schedule, so I've already shared that I work in the emergency department, when they see Dr. Duggan on the schedule, do they say, oh yeah, oh boy, it's going to be a great shift. No matter what happens, we're going to handle it, we're going to roll with it, and we're going to be positive? Or do they see it and go, oh man, Dr. Duggan, she's going to push us too hard, she'll never let us close, it's just going to be a painful day, and I think I'm feeling a little bit ill and I'm going to call in sick? So it really, you have to be honest with yourself. When somebody sees your name on the schedule, what do they think about? Because that really is determining culture. I came from a professional corporation where we had a 16-member ED group, and we would have our services farmed out to the hospital. And so one of the things that we did to evaluate each other was we actually looked at the number of call-ins that each emergency department provider had. And we had 2 providers that were well outside of the mean for the number of call-ins that people had on their specific shift. So when people saw their name on the schedule, they either called in sick or they wouldn't come in if that doctor was working. And so it really is important to, if there is somebody on your staff or in your world who is creating that negative feedback, you don't help your patients, you don't help the culture, and you don't help the staff handle that. So what we have to do is, again, if we're truly being highly reliable, we have to be honest about that and either help that person change their behavior or help them find, what, someplace else to work. It's okay. You know, we have to be serious about this. So why does this matter? Why does the behavior matter? Why do the outcomes matter? Well, in 1998, there was a study that to err is human. That was from the Institute of Medicine, and it was published in 2000. And their estimate in 2000 was that 44 to 98,000 patient deaths per year occurred due to medical errors. And so then they repeated the study because they said they can't possibly be right. And they found that when they repeated the study from 2001 to 2003, that actually it was almost 300,000 patient deaths from medical error, or almost 1 patient per day. Another way of thinking about that is 1 out of every 7 Medicare patients are injured during their hospital stay. Can you imagine if you were getting ready to go drive your car and 1 out of 7 times you got in it, you were injured? Or if you were getting ready to take a commercial airliner and 1 death in every 378 flights? Would you even consider taking an airline? So we have a responsibility to our patients to figure this out and get this right. So think about someone you love being admitted to the hospital. What do you worry about? Falls. Absolutely. Has anyone ever had someone that's had a fall, that a loved one that you care about? Life-changing, eh? Yeah, so when you have a fall like that is entirely preventable, it's just something we have to do better. What else do you worry about with a patient getting admitted to the hospital? Infections. Yes. So what happens when you don't see one of your colleagues washing their hands? Do you go say something? Or do you just mumble to your friend, geez, so-and-so didn't wash their hands again? You know, we all have to own these behaviors, and if we're serious about really enforcing them, we have to set that standard for excellence and then really go after it. So infections, falls, what else? Medication errors, absolutely. How easy is it to have a medication error? How stressful was it when we were transitioning, over to our new EMR with the, the Cerner One chart? So it's being that hypervigilant, that preoccupation with failure and trying to figure out where things could go wrong. So being a patient or having someone you care about as a patient is an incredibly mind-changing experience when you're used to being on the caregiver side. So, patient's perspective. What do you want when you're a patient? Don't hurt me, heal me, and be nice to me. So, really that's what it takes. Serious safety events. What is a serious safety event? Death? So a serious safety event has to have 2 things to classify it as a serious safety event. There has to have had an event that actually reached the patient, and there has to be a breach in the standard of care. Because we all know that we can sometimes do everything right in a patient's hospital course, and that person will still have a bad outcome. So we really want to be careful when we're talking about serious safety events. These are events where there was a breach in the standard of care and that harm directly reached the patient. What about a precursor event? A precursor event actually reaches the patient, but there was really minimal harm or no detectable harm. So, for example, if you had a patient have a blood sample drawn and then you had missed one of the blood tubes and you ordered a red top instead of a blue top and then you had to go back and redraw it, that was an error, but it wasn't necessarily significant harm to the patient. Now I'm a big baby, so if you poke me twice, I might not like it as much, but you know, it's those kinds of things that reach the patient but are not significantly harmful. And a near miss is when the harm does not actually reach the patient. So say that you had pulled up the lab labels on the patient, had gone in to draw the blood, and somehow the patients had been mixed up in a different room and you hadn't checked the banding before you drew it. But then as you were getting ready to draw the blood, you asked the patient's name, double-checked the band, and realized that you had the wrong patient. So when that happens, that's a near-miss safety event, but no harm actually came of it because the event didn't actually reach the patient. And so it's kind of when you think about that triangle of events, we really want to have a whole lot of near-miss events so we can learn where our opportunities are to have a more consistent system so we don't actually go all the way up to a serious safety event. So this is the current classification. We have serious safety events A through E are kind of mild to moderate harm, but when you get into the F and higher, those events are much more significant. And because we're part of the National Ascension Ministry, all of these events are recorded the same way across the country. And what's exciting is that as we really work across the country to continue to develop the principles of high reliability, we're trying to move the mark and actually harm less patients than we ever have before. And so that's why it's important that when you have an event of harm or a precursor event that you actually log it, because you're not only logging it for our ministry locally, but you're logging it for the national ministry. So we've got about 160,000 employees nationally, and if all of us are committed to this journey of safety, think about what a difference we can make. And instead of having 1 in every 378 patients have harm, maybe we can get it up to 1 in 10,000 patients. Because really, even though you know the odds, it's not really meaningful until it happens to you or someone that you love or care about. So another story, my mom has made me a much better care provider because I did not understand what it felt like to be on that other side in the role of a patient, or even scarier when you're not the patient, when it's somebody you love that's the patient and you have even less control over it. And so how many of you know about catheter-associated UTIs or CAUTIs? Yep. Do you think they're completely preventable? So how do we really prevent the catheters completely?
If you don't have a catheter, you can't have a CAUTI.
Right. If you don't have a catheter, you can't have a CAUTI. So my mom, after her first stroke, she had it was the hypertensive bleed, but it was a very small bleed. It was in the center of her brain, very close to the brainstem, so a very scary place for a stroke. She was weak on the right side, but she could still get up and move, really confused, really tired, but it took a lot of work to get her up and get her on the toilet or get her on the bedpan. So what happens? Put a Foley in her. So they put a Foley in her, and sure enough, she's starting to come around. Like the second day, she's really doing much better. Third day, she's actually grabbing onto the walker and really moving and really proud of her. And all of a sudden, she just tanks. And she just goes back to completely, very minimally responsive, starting to get flaccid again. So they run down, do another MRI. Nothing new is showing on the MRI. On day 4, after her initial event, she spikes a temp. So I'm like, anybody check the urine? She's got this Foley in. And sure enough, massive UTI, gets septic, transferred to the ICU, nearly dies, on pressors, prolongs her stay by probably a full week. But the hardest thing was to watch her have to fight to regain all of that little bit back that she'd gained after the stroke, because it was like she had another stroke and had to start all over. So her therapy ended up being almost 2 weeks behind. And the way I explain it is my mom is not a dot on a graph. My mom is a patient that had a Foley she didn't really need. She got a CAUTI, and it affected her care. And so, you know, you get passionate about these things when you actually see what happens. I didn't understand that when I was doing my clinical ED shifts. I put Foley's in a lot of patients that didn't need it. But you have to learn. And so as you learn those things, it's not enough just to, you know, change your practice. You become that person that spreads the joy of change to everyone else, because it really makes a difference. If we can help one person not get a CAUTI, it will change their course. So don't ever think that what you do doesn't matter. So here is our serious safety event graph. And as you can see, we have patient names on here. So December 7th of 17 was Stephen, who was a failure to treat. We have Charles, who was medication related. Charles also had, in November, a failure to treat. So when we look at these things, these are not just dots on a graph. These are patients that we have actually harmed. Because if you remember, a serious safety event means that we had a breach in the standard of care and the harm reached the patient. So one of the reasons to graph this is to look at your trends, and are we increasing or decreasing our serious safety events? And when we look at this through March, our trend across our health system has increased. Now, what's our first thing that we want to say as clinicians? Oh, it's increased because we're reporting more. We're better at reporting. And that may be, but the fact is we have an opportunity. And so we just have to acknowledge the fact that we have an opportunity, and when you group these, you can see that a whole lot of these are delay in treatment. So when we do the drill down on the delay in treatment, we need to be able to escalate up concerns, particularly to our medical staff. So we want to protect our physicians, we want to handle as much as we can, we want to function at the top of our license, but we don't want to feel like the patients are put at risk. And so we need to follow our chain of command. If you call someone and don't get a response, then you need to call the chairman of their department, and then the next thing is, you know, to call the chief medical officer. If you're trying to, a physician calling in to reach a nurse and you can't reach the nurse that you need, you call and ask for the nurse manager, and then you call and ask for the CNO. We just have to increase that communication. How many average people does it take, or how many, I'm not saying that very well, how many errors occur on each serious safety event on average? 1, 2, 7. So when you think about that, there's 6 times that we can prevent an error from actually happening, but we have to then do something. So just think about that when we are talking about the errors. It's being willing to recognize and to escalate up if you have a problem, to make sure that everything is making sense. How many of you have read the book Malcolm Gladwell's Blink? I highly recommend it. Did you like it? So Blink has for clinicians especially, it talks about how you have this innate sense when you walk into a room, especially with your years of experience. An experienced clinician in about 34 seconds can tell you whether or not that patient is going to need to be admitted, not admitted, is really sick, you know, is going to be able to go home without having any tests, without doing anything. It's just your brain is this remarkable beast that has actually stored all of this information in, and then you actually compare it to what you already have in your computer. So when you think about that, just read the book, Malcolm Gladwell's Blink, and you will have a whole lot more understanding and willingness to be able to trust that gut instinct when it happens. And so then when your gut instinct is telling you something is not right, listen to that inner voice. That was my point with thinking about the serious safety events. When we do the drill down on these, many people will say, oh man, I really thought that wasn't right. Oh man, something didn't quite make sense with those labs, but I was in a hurry and I just didn't question it. So, any questions on the serious safety event graph? Okay. So this is our serious safety events by category, more informational. Mild harm is everything A through E. Moderate harm is F and higher, and we have very few deaths, so we're very fortunate on that. So why events happen? Has anyone seen the Swiss cheese diagram before? Yeah, so what does it mean to you?
All the barriers failed.
All the barriers failed. So what we try and do in healthcare is put up checks and barriers to prevent human errors. Are we ever going to fix all the human errors? Absolutely not. I mean, you get up, you get distracted, you think of something else, especially in the ED, it's chaotic. They've actually done a study that in the first 20 minutes of an emergency department physician's shift, you actually exceed the number of human interactions that lead for a healthy life in those first 20 minutes. Because your name is constantly getting called, you're getting badgered, you're looking at the labs, you're looking at the computer, you're running back to check on a new patient, you got a third patient coming in. And so it's really important that we put up these barriers, that we do a timeout, that we do a stop and make sure that I've got the right patient. It's very important that we set these barriers up and that we faithfully follow them, because then we will prevent the errors by putting up the barriers from actually happening. So safety is a dynamic non-event. I love that quote. Think about that for a minute. Safety is a dynamic, meaning we have to be actively involved in it, non-event. So by being safe, we've erected a whole bunch of barriers so the patients don't know it and don't feel it, but we, as being their responsible caregivers, are able to prevent them from having any harm. So let's look at a specific example, the Swiss cheese model of a wrong site surgery. There was a department priority focused on efficiency and room turnover. Anybody ever had that? Okay. Very experienced surgeon, 20-year veteran, extremely competent. So familiarity, he's been doing this for 20 years, experienced team. The assumption is we do this really well, we have this, we're gonna keep doing what we normally do. So lack of organizational learning. They'd actually had a wrong site surgery about a year before, but it was a year ago and things kind of slacked off. Busy OR schedule, first case was canceled. So you know what scramble that causes. We don't want to waste OR minutes. We want to bring that second case in right away. So hurry up, go get that patient, go get that patient. So a decision was made. Let's keep the room set up for the left case, even though the right case was getting ready to be done. Because to take down the setup and put the setup back up was going to take too much time. The doctor knew which case it was. They could mark the correct side and it would be fine. But the doctor ran to talk to the family. The resident marked the surgical site instead of the surgeon. There was no final active timeout prior to the start. And so you end up with the wrong site surgery. So you look at that and you see at any point, you know, a stop and a check would have helped. We had a significant event of a wrong site surgery at a previous hospital that I worked at. And it would have been much worse, except the scrub nurse, when the doctor was getting ready to actually make his incision, and this was a testicular case for a torsion. The doctor was getting ready to make the incision, and the scrub tech said, "Hey doc, I think it's the wrong site." And this young man had not been a scrub tech very long. He was in his, I believe, second or third year as a surgical tech. And this surgeon that he was scrubbing in with was not necessarily the most approachable person. Very dominant personality and was just kind of push right through and the definition of old school, and he was ready to go on that case. And so when I was doing the debrief with the team afterwards, I said to the young man, Jamal was his name, I said, "Jamal, I said, what made you speak up?" And I will never forget what he said. He said, "What happens if I'm right?" So he spoke up because if he was wrong, the guy might yell at him, but if he was right, he saved that child from an extra incision, you know, on his testicles, potentially saving his, you know, virility. So it's having the courage to speak up, and that's what the young man said. He said, "You know what, Steph," he said, "if I was wrong, I might get yelled at and shamed, and, you know, the guy might not like me anymore, but oh my Lord, if I'm right, how do I not speak up?" And so it's having that courage to actually do the right thing that was a great save. So what about the philosophy of human error? I don't know how many of you like psychology. I find it fascinating, and I think that the more we learn about psychology and the more we learn about, you know, neurosciences, it's just a very interesting subject. So in 1890, William James wrote Psychology Volumes 1 and 2, and he described human thought and behavior as being tied to habit, memory, attention, and will. And if we fail at any of these, we can result in human error. So think about the errors that you make during the day. Are they tied to habit? You know, I drive the same way to work every day, so I might miss my exit just because I wasn't paying attention. Are they tied to memory? Have I not done enough clinical shifts that I need to really watch my diagnoses because I don't have the memory that I had when I was doing 16 a month? What about attention? You know, am I truly engaged in the task at hand? Or is my mind running through the grocery list, the, you know, fight the kids had this morning, the new puppy, and is he doing okay? I mean, we have to make a conscious effort. Some of us have to make it more than others to truly pay attention to what is actually at hand and the task that we're doing. And then the will. If we're just tired and burned out, and I saw Dr. Blair here just a minute ago, we're doing some work with physicians and caregiver burnout. It's just really important that you can't give what you don't have. So if you just don't have the will and you're just in a place when you just need a little break, it's okay. I think healthcare is one of the hardest fields to maintain your sanity in. Now, we might be biased because, you know, I've been in it for almost, well, a lot of years now. We won't say how many. But just keep those in mind that that's what happens with human error. So let's look at each of these a little bit. Habits. Habit diminishes the conscious attention with which our acts are performed. We must make automatic and habitual as early as possible as many useful actions as we can and guard against the growing into ways that are likely to be disadvantageous. From 1890, that guy was pretty smart that he was working on these things. So you want to create safe work habits and eliminate unsafe habits. So what's an example of a safe habit? Seat belts. Absolutely. Seat belts are a safe habit. Helmets. You know, bike helmets. What about an unsafe habit that we do at work? Sorry? Recapping needles, yes. Yep, what else? What are some other unsafe habits? Not washing your hands. We have a hand washing compliance rate of somewhere around 90%. How crazy is that? We know it prevents infection, and yet we just, you know, get busy. Oh, I just used sanitizer a few minutes ago. I don't need to wash them for this patient. We give ourselves all kinds of excuses, but if we just got into the habit that every time that's what we do before we go see that patient, it's just how we deliver care. What else?
Ignoring isolation precautions.
Ignoring isolation precautions, yep. And patients are starting to get wise to these things. We're starting to get comments now that, you know, my caregiver, my doc, my nurse, you know, didn't wash their hands when they came to see me. You know, it matters to them, and it matters to anyone that's ever had a hospital-acquired infection. So all of these are unsafe habits that we want to try and break, and then start new habits that will be safe. What about memory? The more a new fact can be associated with linked to something in your memory, the easier it is to recall. How many of you have a horrible time remembering people's names? So when you meet someone, you want to try and associate that name with something that will help you remember. So it's the same thing when you're trying to put new healthcare events in. The more the event and the more often it occurs, the easier it is for the mind to remember to recall it. So when you're doing a procedure that you haven't done for a while, you need to really pay extra attention and perhaps even run through a practice run if you've got time before you do that procedure. I hadn't done a chest tube in a while, and I was working in a single coverage emergency department, and a person had about 3/4 of the lung collapse on the right side, so I needed to do a chest tube. Have I done 200 chest tubes in my life? Probably I've done closer to 500, you know, counting residency and everything, but I hadn't done one in about probably a good year. And so it was very important for me before I did that chest tube to actually look at the setup, make sure I had everything laid out, talk to the staff, because in a more rural emergency department, the staff probably hadn't done 100 chest tubes all combined. And so it was really important that we walk through that exercise. You think, oh gosh, I don't have time for that, 3/4 of the lung is collapsed. You do. You put the patient on 100% oxygen non-rebreather. The 2 to 3 minutes that we took reviewing that procedure made that a safe procedure for that patient. So there's always time for safety, and that's one of the habits that we want to also create. What about attention and will? The mind of a person must actively make itself pay attention to a situation. How many of you remember driving to the hospital this morning? Honestly? Remember the whole drive, every stop? Yeah. The more familiar an object or task is, the less attention is required. And you know, the majority of our actions don't need our close, undivided attention, but we do high-risk things every day. With pharmacy, you do the medications, you give them out, you profile them. But each one needs to have that extra special attention when you're actually, especially when you get to chemo and some of the higher risk medications. So it's important that we consciously make that effort to stop, focus on the task at hand. We were having some additions built on our house when we lived up in Michigan. And I had a wonderful contractor who had great visions in his head, and so he designed our new room addition, which was kind of like just a great room, and he designed it on the back of a napkin, which we then officially signed, and that's just how he worked. He was one of those truly creative, wonderful, wonderful folks. And so he said that he could not multitask. And so, because he always made fun of me because I tend to do things rapid fire. It's hard for me to really sit still and focus on something. Watching TV, I'm always crocheting. It's what I do. I don't like to, I have a very hard time with that. And so he's like, Steph, he goes, I'll bet you can multitask and do the laundry. He goes, if my wife asks me to go do the laundry, I stand there and I watch the dryer. And it's how he thinks. And what we all that have that little more of a touch of ADD, we have to, when we get into these very detailed tasks, we have to focus on that and let everything else go. So it's just a reminder that you have to have the attention and the will to change what your normal comfort zone is. All human makes mistakes, right? We talked about that. We're never going to completely take away human errors. Some of it's cognitive, some of it's loss of attention, lapses in memory, poor concentration from fatigue and multiple stimuli. Just every day at the office, right? I mean, this is what we deal with every day. Accidental factors, complex events, high levels of uncertainty, ill-defined problems. Patients never come with just one diagnosis, right? We all want every patient to have one simple thing, just be renal failure. It's never just renal failure. You got hypertension, you've got diabetes, everything gets more complex. Competing goals, time pressures, and fatigue. So any questions on that, on errors and thinking through it? Is it making sense? Yeah? Okay. So as we're performing, we can have skill-based errors, rule-based errors, and knowledge-based, which is kind of similar to what William James had said. This is just in a little bit more modern terms. So skill-based errors. If you have and you know what you're going to do, but then you accidentally do something else instead, you're failing because not what was done. It's not from lack of knowledge or planning. You just absolutely didn't do the right thing. You went in and you were going to check for those 2 patient identifiers. You know that you should, but you got distracted by something else and forgot to do that. So that's a skill-based error. So if truly safety is our foundation, these are skill-based errors. I do not have time for 2 patient identifiers. We're so far behind. I need to double check the facts on this report, but my manager needs the report for a meeting now, so hopefully the facts are accurate. You gamble, you roll the dice. I know I should do this timeout, but I know it is the correct site and I have no time for delays. So those are skill-based errors. You know the right thing to do and you just consciously decide, I don't have time for it. So what about rules? The actions go as planned, but the plan itself is wrong. We might have too many rules that can be remembered. So sometimes you are looking at a patient and it's that square peg in that round hole. I want this patient's problem to be from lumbar spine pain. We'll just go, I want them to be musculoskeletal in pain. So you are convinced of that. You know what, you give them a shot of Toradol and that patient is actually improving and doing much better. And then as you're getting ready to discharge your patient feeling very good that their pressure came down, they start having an increase in pain again. And so you're still trying to get that square peg in that wrong hole and you check their blood pressure. Oh, their blood pressure's up. Well, it must be because they are having pain again. So I'm still gonna let them go. I'll add a little bit of oxy and just to have them rest. What if that square peg isn't right? What else could that be? AAA? Yep, or a dissection. So you've got to, when it's not fitting and you're rushing, you're just trying to make it happen, take that second look. We're gonna have a really, keep that in your mind because when we get to our great saves, we had a great save on a nurse that truly saved the life of a patient by actually listening to what that patient had said and not discharging them. So has anyone ever heard of normalization of deviance? So normalization of deviance is, you you have a surgeon who tends to, and I don't know why I always go to surgeons, it's not intentional, but I do think that our surgeons are incredibly gifted and special people, because to have the kind of confidence to go in and cut open a human body and do that kind of work is absolutely a true gift. I love emergency medicine because I like to fix whatever comes my way. I don't like to take something that looks good and then cut it open. You know, so everybody gets called to do what they're meant to do. And so what happens sometimes is under that pressure, and the field attracts you because you want everything just right, you have a doctor that is routinely aggressive and not necessarily making everyone feel like they're part of the team. Kind of like the urologist that I had described previously, that the young man had said, hey, I think that this is the wrong site. And so you just come to expect that when Dr. A is in the OR, oh, that's just the way he is. He occasionally throws stuff or yells or swears or, you know, drops F-bombs, but he's a great surgeon, and that's just what he is. That's just considered a normalization of deviance. So you just escalate up what would normally be considered inappropriate behavior, but because it's kind of been a gradual working up, it's just kind of the way it goes. Is that a safe environment? No, it's not a safe environment at all. And it becomes very unsafe because not only are we not willing to stop and engage and really think about what's going on, but we're not willing to stop the line if there's something that we feel is not correct. And so it is absolutely the right thing to do to push for excellence and to push for competence and to push to make certain that your knowledge is up to par. But there's a way to do that without belittling people. It's like watching your great coaches, and here in Alabama we're blessed because we have some incredibly gifted coaches, and you listen to them and hear them speak. They motivate kids, they treat kids differently based on how that child learns, and we need to do that same thing with our colleagues and our peers. So what about knowledge-based mistakes? Occurs in new situations when the solution to a problem has to be worked out. Mistakes occur because there's not a good mental model. So really, I think knowledge-based mistakes, it's okay to not know the answer, but it's not okay to not find out. So again, I like to teach with stories. So I'm a third-year medical student, and I'm getting supervised by a second-year orthopedic resident, and we're on our emergency medicine rotation. And so he's rotating through as a second-year ortho, and this guy was brilliant. I mean, beyond brilliant. Like, we all knew that he got the perfect score on the USMLE, which we're all just like, you know, just want to pass, P equals MD, you know, I'm good. And so this guy was literally brilliant. And we were in a patient's room, and the patient's potassium was 2.9. I'll never forget it. And the doc said to me, he goes, push this potassium. And he handed me, you know, like 40 a KCL. I'm like, no. I mean, I'm not like a perfect score kind of girl on the USMLE, but I have good sound common sense to know that that was not the right thing to do, to push that IV potassium. And he actually went so far as to go to his superior and write me up for disobeying his direct order. And sometimes there's just that disconnect in what actually happens. And so you just have to be able to speak up. So I knew that that was not right to push IV potassium quickly like that. And he just, for some conceptual reason, couldn't understand that. And so the guy is now a brilliant researcher. You know, he is creating new ways of delivering orthopedic care that I would never even conceive of. But by God, I'm not pushing potassium. So the knowledge-based mistakes, it's okay not to know, it's not okay not to find out. And safety doesn't happen. You know, there's high-risk situations. The hospital is a high-risk situation every day. We're under constant pressure to produce. We're under constant pressure with the DRGs to, you know, keep patients a shorter amount of time and send them home. So it's always a high risk. And I can tell you, with my mom, and again, my mom's my best teacher now, is that when I was taking her home after her first stroke, I was a nervous wreck. You know, I didn't understand all the things that might go wrong. You know, they gave me these medications, and she didn't have, that hadn't paid for Medicare for the medication part, so I go and I'm trying to fill her, what's that really expensive cardiology drug that's not covered? Plavix. So I'm going to fill her Plavix, and they're like, that's $700. I'm like, I don't have $700. you know? And so it's just that whole thing of everything is a risk. And when you see it through the patient's eyes, we can do better with this system. So we need to prevent that. So recognize your high-risk situations. And the reason I brought up that discharge is to recognize what's high risk for your patients. Because when you're discharging them, it's important that we try and understand. We can't solve everything, but sometimes if you're prepared for that, as you're getting ready to go home, it will help. And stop the line and find an expert when you need to. So what about teamwork? Everybody knows teamwork, right? How many of you ever were working in the service industry before you started in medicine? Yeah. So I waitressed for a lot of years, all the way through college and med school. And I used to say when I was interviewing ED residents that I really like to hire people that waitressed or, you know, were in the service industry because, you know, being an ED doc, it's kind of like being a server. It's just a little different knowledge base, but the skill set's the same. You know, you got to be able to be nice to your patients. You got to be timely. You have to be able to triage and prioritize. And we all have that same thing in our everyday lives. And so as we work on this teamwork, you know what makes you feel good. How's your day? Thank you for coming in. You know, smiling at somebody. A lot of the tutor teaching that we've had, it's those little things. We're wired to be connected. Even those of us that are more introverted than extroverted, you still want to know that you're connected with your colleagues. 200% accountability. This kind of goes back to middle school, where if you saw somebody smoking, you were to report them or you were just as guilty as them. Remember that? Sorry, I've got 3 teenagers, so that's on my mind right now. So as you're thinking about that, if you see somebody not wash their hands and you don't wash or say anything, I'm not saying go up and get in somebody's face and go, hey, you didn't wash your hands. You know, I'm saying, you know, hey, you know, Dr. Pierce, I know you're really busy and probably kind of stressed today, but, you know, I noticed you didn't wash your hands. Is there anything I can do to help you? Are you doing okay? So can you help me make the videos run? Watch on YouTube. Let me see if I can make this go. So this is a video. Oh, that didn't work.
Drag the red bar back.
I'm technically challenged, but I find an expert. Now watch the coach. So the coach of the hockey team brings her back out. How many of you have had a day like this? It just doesn't go well. And so that poor kid, you know, the hockey coach, come on, roll it, roll it. And so I just want you to think about this because we say sometimes safety is not our job, I don't have time, it's not right. So this video is...
And salute the men and women serving our country with our national anthem. Please welcome, as voted by you, the fans, our winner of the Toyota Get the Feeling of a Star promotion, Natalie Gilbert.
How nervous would you be? This is a playoff game for the Timberwolves. Mo Cheeks is the coach. Now watch what happens. It's Mo Cheeks. So, y'all, that video kills me. Mo Cheeks, I mean, was it, I don't know how to turn this off. I'm going to need some help, sorry. But was it his job to help the national anthem singer? I mean, he's before a playoff game. There's 70,000 people in that arena. And he took the time, so instead of that kid having a scarred memory of screwing up that she would never get rid of her whole life, he did the human thing. And he went out and helped that kid and lifted her up. And if you Google it on your own, there's other versions of it. He lifted up that whole stadium. I mean, everybody was singing, everybody felt the power of the moment. And how different would life be if we just took those little moments? Life happens in the ordinary moments. And if we just took that and said, I'm gonna do the thing that I'd want somebody to do for me or my kid, we wouldn't have more serious safety events. But it takes the time and the courage and the willingness to do the right thing. And just think about that kid. I mean, I'm amazed by that every time. Sorry. When you see it the next time, you'll know what's coming, and then it's more, emotional. And now I've goofed up again, and I can't make this go forward. Sorry, Kathy. Any questions about high reliability so far? I think we have about 5 minutes left.
Your illustration is very nice that you're having the trouble too.
I have no problems asking for an expert. So this is just about clear communication. And when you talk about clear communication, it really, direct physician, or, person-to-person communication is best because you can see the intonations, you can see the expressions. And for those of you, it's a little hard to see on the cartoon. It's what we say to dogs. Okay, Ginger, I've got it. You stay out of the garbage. You understand, Ginger? Stay out of the garbage or else. And what the dogs hear is blah, 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 Ginger. Blah, 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 Ginger. And so there's another illustration for cats. And you know what the bubble says for the cats? Nothing. It's absolutely nothing. So person-to-person communication, and how many of you have had this, not another email novel from Cindy, why can't you get to the point? I should delete, I don't have time for this. And Cindy's going, man, this is really important. I hope Tom reads it soon. So it's important that you understand your audience and that you communicate with each other based on what you each need. I tend to like bullets. So when you're talking to me, give me bullets. I have friends in HR that love paragraphs. So when I email something to HR, I write in paragraphs. It's just a stylistic difference. So SBAR, if we really want to be clear, it's Situation Background Assessment Recommendation. Anybody know where the SBAR communication tool originated? In the military, specifically on our nuclear submarines. And so what is a more dangerous place than a nuclear submarine run by 18-year-olds? So, I mean, seriously, when you think about it, I mean, that's what we have. And they communicate very clearly. They have an assessment, they have a recommendation, and they communicate up and down the chain to make certain that there is no call for uncertainty. So timeouts versus callouts. Callouts are just updates. Timeouts are very specific. Everybody needs to stop. Everybody needs to pay attention. We talk a little bit about the surgical, the safety checklist. This is the World Health Organization. Atul Gawande really put a lot of effort into getting this right, and he'll be now very busy with his new job as he's the head doc for that Berkshire Hathaway merger company. So keep an eye out for that. I think they'll be doing some really fun things with safety with him in charge of that. So situational awareness we talked about, just make sure that you understand what's going on and that you actually get into the moment. If you find yourself wandering and you're in a high-risk situation, use those safety techniques that we talked about. So this is another thing I want us to just take a pause on, and that's speaking up for safety. So if you hear someone say, I have a concern, that's when you have to heighten your antenna and say, oh, I have a concern. I'm uncomfortable, I'm scared, please stop. But really, as we have this common safety language, when anyone says, I have a concern, just start to pay attention. ARC, we've also done a lot of training with ARC here that Debbie and her team have done. Ask a question, request if they don't modify their plan that you ask for a change, and then you're going to escalate it up. But the point is to have a common language, so when you hear that word concern, that everybody takes a pause. We're teaching the medical staff this, we're teaching the nursing staff this, so we have that common knowledge. So if you're in front of a patient and you're trying to prevent an error, you don't want to cause alarm, you can just say, hey, I've got a concern, may I speak to you for a minute? And really move forward. Now, this is where safety really hits the road when people say they don't have time for safety. Stop, validate, and verify. So does it make sense to me? Is it what I expected, and does it fit in? This goes back to the discussion we had about Malcolm Gladwell and Blink. If it doesn't make sense or something in you seems a little bit funny and you can't really put a finger on it, pay attention to that and try and figure it out. And then you need to verify it, and then you need to validate it. And by validating, it can be checking with an expert. So this is another error technique, stop, think, act, review. And so when you talk about stop, think, act, review, you think that you don't have time to actually take that pause and fully vest yourself in the moment. So I want you to go as fast as you possibly can, and I want you to say the color and not the word. Okay, everybody ready? Ready? And your mark is set, go. Go fast, go fast, go fast. Go fast, go fast. Okay, stop, because all I hear is, So we're gonna try it a different way. And we're going to try it just with a half a second pause, and you're going to say the color and not the word. On your mark, get set, go. Green, red, yellow, purple, orange, green. Okay, so that was discernible. You hear the difference. How can we say we don't have time for safety when that's all it takes? All right? So just keep that in mind the next time you think, I don't have time for this, I don't have time for a timeout. It just takes a half a second. Stop, think, observe, plan. So stories of harm. We talked about these with the wrong site surgeries, but I really want to get to are the safety stories. So with the safety stories, the very bottom one, RN addressed the patient complaining of new onset back pain prior to discharge. Record reviewed and escalated concern for dissection to the MD who ordered the appropriate tests, and the diagnosis was confirmed. That was a very real event here where all of our safety behaviors worked, and that patient had her surgery, and although dissections can be very, very high mortality, this patient is living and walking around because that nurse took the time to actually escalate and use all of her safety behaviors. Absolutely life saved. So expected behaviors. 200% accountability, open commitment to safety, clear and concise communications, and paying attention to details. How do we know if we're successful? We observe and hear associates saying to each other in the hallways, hey, I've got a concern. We have our serious safety event graph going on a downward trend as opposed to on an upward trend. And we hear, you can see it when we know that we're doing a really good job and we have confidence that all of the systems will work together. You can absolutely see that in people's faces when you're doing your day-to-day rounds. So questions, comments? I really appreciate y'all spending your lunch time with us. I know I rushed the last little bit, but I do try and end on time. Sometimes I just get excited, and then I had my bobble with making the videos run, but I think they're worth it, so I fuss with them every time. Thank y'all.